KYKS 105, good morning. It's become quite the tradition now during Heart Month in February that we team up with our friends at St. Luke's Health-Memorial in Lufkin, where we talk to many of the cardiologists, many of the folks that offer heart care there. And basically, this is an education day to kind of hopefully, if you haven't maybe had your heart checked, had a stress test anytime in the past, recent history, that you may maybe do something like that. And we bring in some of the experts, and one of those is with us right now. We have Dr. Saini, who is specializing in cardiovascular disease and clinical cardiac electrophysiology, with extensive experience in cardiac electrical system procedures, cardiac implantable device procedures, and heart conditions. And he's trained all over the country, everywhere from nearby like LSU Shreveport to places like Richmond, Virginia, Baltimore, Washington, D.C. And thankfully, he's back here with us in Lufkin. So good morning. How are you doing today?
As usual, it's a pleasure. I'm doing great, Danny.
Wonderful. So let's go ahead and, I did the intro there, but if you don't mind, kind of dive a little bit deeper and explain to us what is it that you do as a cardiologist, and tell us about some of your specialties.
Yeah, to put it in simple terms, I am like the electrician of the heart.
Right.
So I'm a heart doctor who specializes in heart rhythm problems, in treating heart rhythm conditions. As you know, there's a lot of heart rhythm problems which are called arrhythmias. When your heartbeat goes out of rhythm, goes too fast, goes too slow, I specialize in dealing with and treating those problems, like doing procedures for putting pacemakers, putting defibrillators or shock boxes in their body, and also mapping the electrical circuits of these heart rhythm problems in patient's body, and then burning or freezing them, which are called ablations.
Right. And we'll be diving some more into that as our conversation continues. But as far as coming to see you, what would somebody actually usually go through their primary physician before coming to see you?
Yeah, since I'm also a cardiologist, and just like my other colleagues, I also receive patients from the primary care doctors and treat them for various heart conditions. However, at the same time, I receive referrals from number of cardiologists in the area, in Deep East Texas, of course, at the Heart Institute, for specifically treating heart rhythm conditions, which, of course, for which I received specialized training and completed specialized fellowships in.
And you started talking about some of the different equipment that you use. So let's dive a little deeper into that and kind of start, first of all, with pacemakers and what is it that they do and what is it that you offer?
So pacemakers have been there for decades now, and pacemakers are basically devices which are there to treat slow heartbeats. Patients who are having extremely slow heartbeats or a disconnect of the electrical wiring between the top and the bottom chambers of their heart. The heart does not beat in sync, the two chambers of the heart. So the pacemakers may help first elevate their heart rates to the normal levels, and also bring the synchrony back to their top and bottom chambers of the heart. So I think these have been there for a long while. What has happened recently is they have gotten smaller, the battery life has gotten better, and the techniques of putting pacemakers have gotten a little safer, and we are able to put pacemakers directly now into the electrical wires of the heart, making use of the normal electrical circuit of the heartbeat. And that way we can prevent complications associated with pacemaker implantation, such as heart failure. Sometimes pacemakers, even though they are great for patients, but if you use them a lot, the heart doesn't beat the right way as it was designed to. So over a period of years of using the pacemaker all the time, the heart can get weaker and develop a specific type of heart failure, for which we traditionally used to add wires to the existing pacemaker or upgrade them to a defibrillator sometimes. But nowadays, in the very first place, when we put the pacemakers, technologies have come where we can directly use the electrical wiring of the heart and make the pacemaker help the heart beat the normal way.
So it's like hard wiring into the electrical impulse. That's great. I love that.
Rewiring the electrical circuit of the heart.
You touched on defibrillator, so let's go ahead and talk about that next, if you don't mind.
So a defibrillator, on the other hand, is for fast heart rhythm problems, dangerous life-threatening rhythm problems, for cardiac arrest. When we hear about someone who died suddenly or just blacked out, and we often call the EMS. We often see it in movies that the EMS comes in, connects patches to their chest, and they find that their heart is beating in extremely fast, irregular heart rhythm. It is called ventricular fibrillation or ventricular tachycardia. And this is the commonest cause of sudden cardiac death or cardiac arrest. Okay?
Right.
In these situations, the only thing that determines who is going to make out of it and who is going to make out of it with sanity left is the time to bring them back into normal rhythm. So that once they are in normal rhythm, the heart starts pumping back again and delivers blood to the brain. So the time to shock and bring them back out of rhythm is what determines who is going to make out of it. Okay?
Okay.
Defibrillators are devices which are designed for appropriately indicated patients, such as those with heart failure, which are just like pacemakers inside the body, but the wire has the additional capability of delivering a shock when it sees that the heart is going out of these rhythms. And the shock can be delivered within 45 seconds to a minute. And that saves a significant amount of minutes in restoring heart rhythm, and thereby helps patients come out of these rhythm problems to be able to make it to the hospital and be evaluated by the doctors further as to why this happened and what they can do for the rhythm problem itself. So.
And kind of maybe a different tangent here, but we kind of saw this play out on a national stage at a football game. You know,
Yes.
I'm sure you're familiar with that. How I think a defibrillator was used in that instance as well.
Absolutely, even younger patients often require defibrillators because either due to certain genetic conditions or familial conditions, they have some abnormalities of the normal electrical channels of their heart, and some mutations that may result in them being more prone to having ventricular fibrillation or ventricular tachycardia, even without the presence of heart failure.
Right.
They have a completely normal heart structurally, but electrically it's screwed up. And when certain things trigger, that rhythm problem, they can have the same issues that a heart failure patient would have, and their heart would go out of rhythm, and then they can black out, they can die from it.
Right.
And often the defibrillator save lives in those patients,
Absolutely. So what are some more of the chronic problems that you treat here in the East Texas area?
Well, within the realm of heart rhythm problems, of course, we have an aging population in East Texas. So we have a lot of pacemakers we implant for patients who have slow heart rhythm problems. We have a lot of patients with heart failure, and hence a lot of patients who require defibrillators to protect them from dangerous heart rhythm problems. Then we have a number of patients with the common heart rhythm problem called atrial fibrillation, which is when the top chambers of the heart go completely out of sync and start beating very fast. And, this prones the patient to have stroke. And it's one of the commonest causes of stroke. So we perform procedures called ablations for managing the atrial fibrillation, the rhythm problem itself. And often we have to either put them on blood thinners, but because of our aging population, many of them cannot be on blood thinners because they have bleeding problems when they go on blood thinners because of either, gastric issues or polyps or colon disease, and sometimes unexplained anemia. And so we did not have an option for such patients to protect them from stroke 10 years ago. But now, especially over the last 5 to 6 years, the Watchman procedure and the amulet procedures are specific procedures which are basically in which we plug in the critical areas of the heart on the left top chamber where the blood clots usually come from in patients with atrial fibrillation. So once we plug in these areas with these devices, we are able to protect them from stroke without them having to be on blood thinners long term. So this has been a game changer for stroke prevention in patients with atrial fibrillation. And a lot of our patients are now getting these devices. Our Watchman program at CHI St. Luke's has been a roaring success. And I think that's one of the big things that has happened over the last couple of years.
I know that we've talked a little bit about some of the procedures available for heart rhythm patients, but let's go ahead and kind of cross into that again, because this is really important stuff. The state of the art technology that's available for patients right here in the Deep East Texas area.
Yes, so I think broadly we divide them into device procedures and ablation procedures.
Okay.
Device procedures, of course, we talked about pacemakers. We've talked about defibrillators. We talked about how pacemakers are getting more efficient and smaller. And nowadays we are implanting pacemakers called micro pacemakers through the groin itself, which are indicated for a certain small group of patients right now, but the indications are expanding. The entire pacemaker is like a bullet which goes through the groin and is delivered inside the heart. So the patient doesn't, when you look at the patient, you don't even know he has a pacemaker.
Sure.
And that's, a lot of patients appreciate that fact that, they don't have a bump in their center of their chest, in the side of their chest, and showing off that they have a pacemaker.
Yeah.
But that's a good part about it. But then there are, of course, different types of risk associated with some procedures like that. So, we have an honest discussion with the patient about what option would be best for them, especially if they're indicated for the type of pacemaker. Now, on the defibrillator side, we have defibrillators which have become wireless also. So in young patients, they're having defibrillators with wires embedded inside the heart makes it harder to ever get those wires out years later if they have an infection or if they have some reasons to get those wires out. So nowadays we have these subcutaneous defibrillators which are coming on the side of the chest, and they have no real wires inside the heart. The wires are actually tunneled outside the heart but under the under the skin.
Right.
So, those defibrillators are excellent for patients who are on maybe dialysis, who do not have enough vascular access, who have a lot of veins blocked in their body. So, or you need to preserve those veins for other reasons such as dialysis. Right. So those defibrillators will be helpful for those patients. They're called subcutaneous defibrillators. So that's an option on that side. On the ablation side, we basically map the electrical circuits. And when I say map, we have significant technology through mapping systems. These big companies like Biosense Webster, Abbott, and Medtronic, all of these have developed. Boston Scientific, they have all developed mapping systems, which have become better and better as the year goes by. There are software upgrades coming in. Now I'm sure they're going to go into the augmented reality realm in the future. I think that's what's going to happen. So it's made it easier to us to visualize the heart without even having to be actually seeing the heart when we are doing these procedures. The difference between surgeons and us is that surgeons will cut open the chest and actually see the heart when they're doing the procedure. Yeah. But for the cardiologists, interventional, and electrophysiologists like myself, we are not actually seeing the heart. We are not cutting open the chest. We are actually doing everything through the groin or the wrist. So all the more, what we have to help guide us is X-rays. That's what used to be for the last few decades. But now we have mapping systems with wherever we touch the catheter in the heart, it creates an electrical map of the heart. So we get sort of a three-dimensional electrical map, which can help us understand how big the chamber is, where to go, and lessen the use of the radiation which was associated with the previous X-ray systems. So those technologies have gotten better. So once we are able to map these sick areas inside the heart, which are often involved in the electrical circuits, we can ablate them. And ablation is basically delivering heat or cold energy to kill the cells in the abnormal areas so that they no longer participate in the electrical circuit and break the rhythm problem. That would be the best explanation of an ablation. Now, the ablation modalities are changing. In the next 2 years, we will have what we call PFA, or electrophoresis. So we either used heat or cold so far. Now we are getting into the realm of sort of a electrophoresis, which is a pretty normal process. And electrophoresis basically helps to make the ablation process safer. It doesn't hurt the cells around the cells that you're burning. It doesn't hurt the nerves as much. It doesn't hurt the other parts of the body. So it makes the procedure much safer and shorter. And it's going to be there soon. It's already being tried and tested, and a lot of centers have started using it, and we will bring it to East Texas pretty soon.
That kind of leads me to my next area here, because from year to year when we've done this, it's just amazing to hear about how you have this new advancement or this new piece of equipment, or how it's gotten smaller, or how it's now actually put into your heart. And now you're talking about this new stuff that's going to be coming in the next year or two. So I would imagine the training for all this is just ongoing for you guys.
Yes, sir. So you're right. I mean, most of your training is often on the job, because the technology is changing so quickly.
Sure.
And it's so dynamic, the whole field of cardiology, that yes, you do perform your fellowships, and it's obviously great to train at a great center. And I was very fortunate to train at an excellent center, especially for my electrophysiology fellowship. But at the same time, to continue to learn is the key in our profession, because if you start becoming stagnant, it's going to be a problem, because you won't be able to provide the same quality of patient care as people associate with you. So we often have to be humble and sort of keep learning every day, and that's what we are trying to do at the Heart Institute.
Okay, once again, we are talking with Dr. Saini here on this Heart Month Takeover with KYKS 105 and St. Luke's Health-Memorial in Lufkin. And now we direct our attention to a patient named Valley Ann Kerr. Love the name, Valley Ann Kerr. Became your patient. She had already gone through multiple procedures and medications to address some severe heart failure that she had suffered for many years. Let's talk about her and what makes her case so special for you as a physician.
Well, she's a pleasant 65-year-old lady. When she first saw me, she had a very sick heart. She had already been seen by previous cardiologists and has had multiple procedures for the plumbing system of the heart. And the plumbing is completely screwed up despite that, and she will tell you at some point she was so depressed because of all she had to go through a lot, fighting this heart disease. And the biggest problem was that the heart only pumped 15% of the blood that came into it. 55 to 60% is pretty normal. And anything less than 50, we start calling it heart failure. When it comes to 15, it's really bad, severe heart failure. And not only that, the part that didn't, the rest of the heart, which was like the 85%, was completely scarred. In other patients, you have heart failure, the muscle is still moving, it's just moving weak. But this part was completely scarred, which is what made her very sick. And she would come to the clinic. She would always be pleasant and, smiling. But, you could tell that behind that lay the sick heart.
Yeah.
And she was a ticking time bomb. And I told her that, I'm very happy to see you, how you look.
Yeah.
But the day you get sick is going to be bad. So we will have to understand that. And she did. She fought this, and she had a defibrillator to protect her, from dangerous heart rhythm problems because she was indicated for that.
Sure.
And indeed, that's what happened. Eventually, well, she was doing fine. She started having these rhythm problems, which are ventricular tachycardia, ventricular fibrillation, which if she did not have a defibrillator would have killed her.
Right.
But fortunately, she had a defibrillator which kept saving her life. I often give this analogy with an airbag in the car. You have an airbag in the car, which is there to save your life, just like the defibrillator will be saving your life when you have a heart rhythm problem. But that doesn't mean that you keep on having the accident every day. Because one of these times, the airbag will not be able to save you.
Right.
That's what was happening to her. She kept on having the rhythm problems and shocks from her defibrillator despite trying all the medications, and we had exhausted all options medically. And then she landed in the hospital with what we call ventricular tachycardia storm, when your heart is completely in electrical storm, complete disarray, the heart is basically dying.
Yeah.
And the device kept shocking her multiple times. So she was extremely unstable to even transfer or even think about transferring her to any center. At that point, with that weak heart, the long-term only thing that's going to help you is a heart transplant.
Sure.
But how do you get to the heart transplant? Because every time she would try to go to Houston, she would get a shock. She was so scared of driving also to Houston.
Sure.
And when she would be driving, 1 or 2 times, she got a shock while she was actually en route to see her heart failure doctors in Houston.
Yeah.
So she would keep landing into her hospital. So we had to do this very complex minimally invasive procedure. Well, probably the most complex minimally invasive cardiac procedure done in the history of Lufkin, here at CHS St. Luke's, and it's called a VT ablation. Now, we do VT ablations all the time, but she was extremely sick and unstable. The key issue with her was whenever she would go into the rhythm problem, her blood pressure would drop significantly, and you can't keep somebody in that rhythm problem to be able to map it.
Yeah.
If you keep collapsing
low
on you.
Pressure, sure.
And it was never a stable rhythm. It would always go into completely erratic rhythm, so you can't map it. So how do you do it? So, of course, after discussing with her all the risk, and the risk was almost like 1 in 10 chance of even having a life-threatening complication and dying on the table.
Yeah.
She understood all that because we were looking towards hope. At that point, we needed hope, and she needed hope.
Yeah.
And this was the hope. So, we decided, okay, we'll do it. And we accumulated a team, and, I had to rally people around. I had to talk to my president, Dr. Bachi Reddy, and he was supportive of it. And I think I needed that support coming from him.
Sure.
And then I needed to get my team at the hospital ready. And, I'm so thankful to my great team who just, rallied behind me, and they made it happen. Because really, we told Valley that, we may not be able to fix your rhythm problem. Most likely we will not be, because your heart is so scarred, you're going to keep having rhythm problems. But if we are able to slow it down and make it a little stable for you to, and buy you a few months,
some time,
you a few months so you can have that heart transplant, and then talk to your heart transplant doctor, expedite that process for you, I think that would be our best goal. And we were able to perform the procedure. It lasted 7 to 8 hours. No one in Lufkin would forget that procedure who has been a part of it, or he has been even remotely close to that procedure. Will not forget it, because it was very long and very complex procedure. We were indeed able to find the critical areas in her heart which were responsible for degeneration of that rhythm to an abnormal rhythm.
Right.
She still had rhythm problems, but she was more stable after that, and the device was able to get control of it, and the medications were able to better control it. She was able to make it to the point where she could go to Houston, see the advanced heart failure doctor, see the surgeon, and eventually get a new heart.
So that has happened now.
Yes. So she got the heart transplant successfully, and it's a great success story. We call her the Lufkin miracle. And and now she's doing rehab, and she's so happy, and she has a new heart. She's we all are, as physicians, train on all these complex procedures and train throughout our lives, read so many books and, gather that much knowledge. But this is sort of the ultimate gratification and amalgamation of all that. When we have someone who is really sick and you can get them out of such a trouble and really help them as a team out of all this problem. I think that is the real success of modern medicine. And she's a perfect example of what can be done with the tools that we have these days, but not only in big cities, what can be done for a person living in East Texas, near a smaller town, but now we can provide them this type of care locally.
Right.
I think that was what was the key here in this case.
I mean, like you said, it's such a great team effort. Not only do you have the technology and the modern medicine, but you have all these great brains, kind of melding as one, saying, okay, kind of working off each other. And then, of course, you also have the situation here where you can actually talk to some of your doctors in Houston that you're able to get some information from them as well.
I think at CHI St. Luke's Health-Memorial Lufkin, we are partners with Baylor St. Luke's Medical Center in Houston. So I think that partnership obviously is critical to us being able to provide this type of care, to our patients.
Absolutely. And so, how long ago was the heart transplant now?
I think it's been a year now.
Has it been a year now?
Yes.
Wow, fantastic! So for you as a physician, it's important. And what benefits do these relationships bring for you as a physician and for the people in Lufkin and the surrounding areas? I mean, obviously you're able to perform just these miracle type operations, but once again, you have the modern technology to bring to so many people now in East Texas that they didn't have before.
Yeah, so I think God, parents, and mentors, is who I thank all the time, because they give us the blessing, the opportunity and the skills in that order, okay, for us to be able to do all this good stuff for our patients and for humanity in general. I really, feel blessed to be able to have the skills to help patients and, hold their hands when they're dying. If I cannot help them, at least be with them, at the end of life. But many times be able to get them out of critically ill situations. So I think that is the key. And I really appreciate that, all what I have been able to achieve because of the support I've had from my family and my wife and obviously my mentors.
Yes.
But at the same time, all this technology is great. It's fantastic. But at the end of the day, the basics of medicine still matter the most. Okay. What I think is the key and what Heart Institute has been able to achieve in partnership with CHI is that, even the patients really want us to. They don't care about that much about this technology. They don't understand that much of this technology, what we're talking about here, okay? What they care about is the doctor sit down, even if it be for a few minutes, talk to them, look them in the eye, and explain to them what is going on, and, hold their hand sometimes and tell them, okay, this is what we need to do, and sort of get the trust and the relationship going. I think that has always been the critical element of physician-patient relationship. That's the most important thing even today. And all these technologies and everything complement and help us, provide better care every year to our patients. But it all starts at that basic communication. And I think that's what, at least I can say that we are trying to do better each day. Me and my nurses here, Shannon, and we try our best to, even if we're very busy, we sit down and talk to the patients. Even if it be for a few minutes, but when we sit down and talk to them and tell them the key critical elements of why they've been sent to us and what we are trying to do, they really, really appreciate it, I think.
Dr. Saini, thank you so much, number one, for visiting with us. Thank you so much for developing that trust. Thank you for the hope that you've given to so many East Texans, and also thank you for saving so many lives.
Thank you for having me this year. Thank you.